and then I think we could also ask them questions related to the talk. And also, Winnie, do we have any comments from the, no? Okay. Okay, so we have to, but we'll open it up to anyone with questions. And so first of all, I want to thank both of you, because to me, it's also kind of allow me to look at the mirror myself. I share many of the experience, and sometimes, I mean, I think that despite my own best intention, I find that going through the pandemic had been very difficult, and I think probably I have not done as well, like that, that I wish I would, and sometimes not listening too much to the patient, and maybe just getting too tired, and then forget, and then this the humanization aspect actually catch up. Like personally, I feel that sometimes you almost like it's no longer an experience that you enjoy as a doctor to a patient, because it seems to be so kind of artificial, like so like you don't really see what is behind the mask, and so you try to do your thing. It's like more like a job than something that you would take pleasure from. Like, and I also find that maybe our medical system also have really systematic issues, and I think our trainee going through training is also very difficult, like, because of this human disconnection. I do see our trainee, all this virtual care, they're missing something that they will have to catch up in time, maybe like how to talk to a patient, because in virtual care also you have the time constraint, you have a 15-minute appointment, and then you just well, I don't think we ask patients how they feel. Like we talk about the medical aspect, and we always under pressure to just get it through, and then the lack of manpower, people getting sick from the medical health worker perspective, and then suddenly you have to find an extra doctor to cover, and then everybody just scramble, and so that will diminish our ability to provide even very basic or adequate care. Like just try the best you can, and I think that really over time take a toll. Like it's kind of an invisible hand, but it's kind of wear you down. I thought that we are pretty good in dealing with stress, usually acute stress, like a grand proposal. You can work really hard, but it only lasts a few weeks. But like after 1 year and the second year, and it didn't seem to end, that really make it really, really difficult. And so, but I think I also find that for myself, if I'm tired, I have less patience for patient, and even for myself. And then I guess it's just human nature. I guess reflection that I'm not a Superman. And so I think this experience is really kind of this looking at myself through the mirror that you provide is actually very helpful. And I think for myself, I think I have learn a great deal, and I certainly will want to emphasize this aspect. And okay, looking forward, and yeah, I don't know if anyone want to share the experience and comments, and yeah.
One of the problems of modern medicine is discontinuation of care. The continuity of care is not facilitated now by the way the health systems are structured. So that may be contributing maybe also to the problem. The other comment I have is about empathy. The capacity to be empathetic, it changes from individual to individual, and some people are by nature very empathetic and some others are not. And one of the things that, in addition to being trained about communication, maybe being trained about being empathetic, it would be another thing that might be addressed. And I don't know how you do that, but I think it can be done.
Yeah, I was saying to York early on, I think of this as similar to musical or athletic ability, that people vary in their natural or intuitive ability. Some people are more empathic, more attuned than other people, but everyone benefits from training, as with music or athletics. So, and actually, it's not just an opinion. There's actually empirical evidence. People have developed communication skills training program, empathy training programs, and people actually do improve. We don't do that, though. We don't train people systematically in it. We assume that doctors just know how to do it, which they don't, actually. And so I see a lot of unprofessional things that don't occur in other areas of medicine because we train people and we have professional standards. We evaluate people on those other things. We don't evaluate people typically on this. And of course, I think in most settings, when complaints come to the regulatory bodies, they usually come about this. They usually come not about medical mistakes. They come about medical mistakes often compounded by insensitive, unempathic communication. So it's even in the physician's interest to be better trained in communication.
If I can just add a comment, I think there's also a cultural aspect to it, in terms of the healthcare culture, that empathy is not seen, so it's not valued. In fact, many medical students come in, I think when they do evaluation, they come in with a lot of empathy, and then somehow as they ascend through residency and training, the mentorship kind of almost kind of devalues it. And so what you see is you don't see a lot of articles in medical publications about empathy, psychosocial care, but you see it in the softer journals, the Journal of Nursing, Journal of Social Work. It's almost as if these are maternal aspects of care that are kind of split off from the rigorous masculine medical care. It's not valued, it's not quantifiable, it doesn't have p-values, and therefore it doesn't have the same kind of value to it. But I think speaking to what Gary was saying, many people come in with those values and they feel good if they can engage with that. They become increasingly disengaged when they're like in the dialysis unit. We have EMR systems, so the nurses are forced to record all kinds of things during the dialysis treatment. Nobody ever looks at it again. And they'll say, oh, I have 3 patients I'm looking after, but I don't really have time to speak with them because I have to do all this documentation. So the whole system is kind of on this, as you say, on this automatic pilot movement, and you have to actually kind of stop yourself proactively and say, oh, I wonder if I should speak with the patient like we used to do decades ago. Somehow it's not valued, and it's seen almost as if, well, you're wasting time. You should be more efficient.
Since we're at a nephrology meeting, I'll talk about nephrologic related issues. So, the inpatient experience in nephrology, at least in the States, is, I think, fairly overwhelming, because if you're able to talk, you're probably discharged from the hospital as soon as you're able to talk and go to a lower level of care. But, rounding on a weekend, you might have dozens of patients intubated, sedated on CVVHD and ECMO or, dialysis. And there's no talking to the patient. So it's easy to feel like, what am I doing here? You're just treating the machine, you're not treating the patient. And, and the fellows are probably even more burdened than the attending is. Again, at least in the States, they're writing much longer notes and because of our ridiculous documentation requirements. So, and the other issue is when you're on call on a weekend, you may not be the primary, even nephrology provider of the patient. And so if you happen to hit the ICU in the afternoon and you're all of a sudden you're dealing with family, and you actually don't really know the answers to a lot of the questions they're dealing with. So I found it to be a very challenging experience. And, the goal was to get through the day and see all the patients. And and you know, if you think about it, all these people who are intubated and on continuous dialysis or whatever, you know, they're in a terrible state, right? I mean, you should want to feel empathy, but it's hard to do that. So I'm not sure how you bring that about. I can see in the outpatient setting, especially in chronic outpatient dialysis, it lends itself more to being able to work with trainees and attendings to try and bring out empathy. But the inpatient experience is very hard.
I would say I understand that problem. And I would add to that for every one of those intubated patients, you have a family which is deeply distressed. In fact, there's a lot of research on PTSD and family members of patients in ICU settings. I think when you're attending on that weekend, you may not be able to do anything different than what you're describing. But I think that is, I think the solution to that is we need to think about healthcare teams. Someone needs to be talking to the family. It may not be able to be you as the attending on that weekend. And people will say we don't have resources for that. But of course, my point would be that's a decision that's made about how we allocate resources. We've decided that the human aspects of the care are not something that is deserving of resource allocations. And then, of course, we don't have resources to do it. So I do think we need to think about healthcare teams, and I think we need about psychological care. And also, I think doctors need to be able to talk to each other also about the kind of thing that you're talking about.
Another issue is that surgeons tend to round at 6 o'clock in the morning when no one else is around, and then they're gone. So the family's not there, the patient's not there.
And so the primary team, which is like, you know, if it's after, for example, heart surgery or cancer surgery or some sort of surgery, the surgeon's in charge of the team. And so that team needs to get together with the family. And I don't know how that, I think it's a great idea. I'm not sure how to structure it.
I get the sense, like from both Gabriel and Gary, like that part of the problem, systemic problem of dehumanization, is related to this technological advances of our society. The way things now is so-called, because of the digital world that we live in, things are supposed to be more efficient, but on the other hand, the way that system work is that we have lost this interconnectedness of the healthcare team. I think I personally feel like I'm just a member of a big corporation. And, in the past, I felt like a doctor because 20 years ago, we still have a cafeteria that medical staff, nursing staff can go to. You see your colleague, you talk. Now we rarely see each other. Maybe actually in the ICU, maybe you run into someone you may see, and then the way that the system set up is every team, like I would turn look after the inpatient for 2 weeks, and then I hardly get to know the patient, and then I finish, and then another team take over. That means actually no staff actually really know a family very well, like unless some primary doctor would kind of provide some kind of input. And then sometimes we were asked to talk about like major decisions such as stopping therapy, but you have actually no idea about the family, the patient, who that person is. And then suddenly you have a family meeting, and then you just put in the situation, and then you rely on some notes from somebody you actually don't know. And so it's a very disconnected, but this is the kind of world we live in, the digital society. And then the other thing I feel is that a lot of power in the healthcare administration, and they may make decisions that impact on the physician and nurses, but sometimes they may not have a good appreciation of the consequence of they're looking at maybe economical efficiency, but not necessarily like about the complete package of the healthcare mandate, like including, I see like in our elevator, like UHN is ranked number 7 in the world, and provide the best care. But I feel that a little bit ashamed in myself because I don't think we're really doing anything close to that. Like it's a very disconnected care. Maybe if you look at the heart statistics, maybe cancer outcome, transplant outcome, we are doing a reasonably good job. But I think overall, patient satisfaction, I'm not sure really we're doing very well at all.
So, I would make 2 points about this. People think it's not simply about technology, it's about the systems of value, what we think is important. Even in wealthy institutions, high-end American hospitals have huge resources. It's about decisions that are made about how we organize healthcare. And the bias is at all levels. When you look at research bodies where the funding is out, because we do have empirical data in terms of psychosocial outcomes, but it's how research bodies allocate resources, it's how hospitals allocate resources. It's what we view as important. And people just take about what it is rather than thinking about it's actually just an opinion. So it takes leaders who think this is important. The people who tend to think this is important tend to be not empowered in medical systems. And so that the people who do make decisions may not share this bias. The other thing about quality of care is, what do we measure? For example, I could hear in a cancer hospital, for example, when they report on how we're doing with, let's say, lung cancer, they would report survival outcome. But of course, many people with metastatic lung cancer die. We should be evaluating quality of life. Quality of life ought to be, or symptom control ought to be part of the metric. If we want to say we're the best in the world, it shouldn't just be about survival. It ought to be about quality. But we don't do that. We don't. Those things aren't ascribed the same value.
I mean, I was just going to highlight again some of what Gary was saying, that the culture aspects. I mean, if you think about 10, 20 years ago, you would go around the floor and you would write notes. But because you had to write notes, you would maybe spend 5 minutes doing it. Nowadays, I find if I'm doing inpatient service, I may be spending 90% of my day sitting in front of a computer documenting. And in fact, the documentation is reams of pages that you basically cut and paste from other people's notes that nobody will ever read. And you've spent the whole day in the 8, 9, 10 hours, 1 hour in actual patient contact. And I think that kind of shift, creates a sense of demoralization. In a sense, we've all gone into healthcare to have that human connection. It kind of fuels us. That's where we get our energy from. And increasingly, we are removed from that. And I think that Gary also made an important point in terms of we are not trained. So what happens is we don't realize that when patients and families become ill, they become vulnerable. It's as if all of a sudden they are speaking a different language. We go in with okay, here's what your hemoglobin is, here's what you need, etc. And they're going with, but I thought my mother could walk and now she can't walk, and look at what you're doing and it's all your fault. And all of a sudden there's this cognitive dissonance where they're saying one thing and they don't understand it. It's as if we're saying, listen, in this hospital we speak French and you're speaking Italian. So you have to learn to speak and understand my French rather than me wanting to connect with you in Italian. And I think that kind of disconnect in terms of the languages that we speak, in terms of not recognizing where patients and families are, creates an escalation of discord. And then all of a sudden the management is brought in. Sometimes they call a code white and security comes in and things all of a sudden sort of go out of control and you have an explosion.
Hey, thank you both for being here. I appreciate it. I'm a patient of Dr. Pay's, and I can say you've always embodied Superman when you've treated me, so I appreciate that, Dr. Pay. I'm just curious, as a patient, how can I help take on some of that work as well to establish what you guys are saying, a little bit more of a human, emotional connection with my healthcare providers?
Are you involved in that way now?
Under Dr. Pay's care?
No, I don't mean, are you involved beyond as being an individual patient? Are you involved in some other way in the healthcare?
No, I'm not.
So I think more and more, I think we need patient partners. The kind of things we're talking about are something that every patient and their families know it. Everyone that I see, everyone knows that how the doctor talks to them is important, whether the doctor is interested in them as a person or how the disease is affecting them. Patients and families know this better. They need to be partners. So there need to be structures in healthcare, in renal disease, but in healthcare more generally, where people like yourself and other family members are actually giving input. They're the voices. And they get to say, when you talk about the quality of care, your voice is certain, the medical people know some aspects of care about the quality better than you do, and you and your family know other aspects, that in terms of the human experience of cancer. So I think there need to be those kind of patient voices that are giving feedback about the care and also providing input on how the care is delivered. And there are structures. Actually, at UHN, there are patient partner structures, and many hospitals do. And I think those partners also need to come from diverse communities. That's another thing. There are all kinds of needs of people who don't speak English or from marginalized communities of one kind or another. They need to be represented too, which they typically have not been.
Okay. So I don't know if there's any comment, and just let me just check the agenda. Okay, so we are okay. I don't know if you have any more comments or discussions. Okay.
How do you help hospitals or systems realize the value of the humanization aspect so that they will allocate resources? Like, what could be a strategy that could be implemented by professionals, or what could you push towards the higher level where they're looking very much at numbers?
Yeah. Again, I don't have the full answer. Like, it's interestingly, Humber is actually now going to have a wellness officer. So it's somebody who's sort of, I guess, at the VP level with, I guess, a mandate mainly in terms of helping physicians develop those kinds of skills or helping physicians with burnout, et cetera. And so I think that in a way there is a growing realization by institutions, and I think this has been happening more in the States, and they're further ahead of us than in Canada, where there's a recognition of those emotional, psychological shifts in staff and the need for hospitals on a systemic basis to do something. And now you could say some of that is driven by people resigning and leaving, and there's a need to, there's now a stark need to provide something, but at least even being able to name it and realizing that there's an issue and allocating resources to me is a positive.
I would say, my strategy for this in my work in cancer has been several-fold. One is, I think people who value this, psychosocial people in particular, are far too humble. And so they too easily accept the fact, well, of course there aren't resources for everyone. We just have to accept that's the way it is. I think they need to speak with a stronger voice. The second thing that I've done is try to identify medical leaders who will speak for this, because it has an additional credibility. If I'm a psychiatrist, if I say this is important, it's easy for people to say, well, of course you think this is important, you're a psychiatrist, But if people like you and your speak up, it has a greater influence. And so I've also tried to look for medical leaders with influence who have what I call emotional intelligence, who understand this is important for patients. And also, even from a business point of view, understand that it's what patients and families value. Patients and families want it all. They want the best medical care, of course, biological care, but they also want human care. And so that it's actually good for the business of healthcare for people to do that. And the third thing we've done is look for patients and families to speak up, but also for philanthropy. That we've had philanthropic support. A lot of the initiatives we're developing, including our Cancer Experience program, come from philanthropic support. And the philanthropic support does two things. It allows us to build these programs, but also it gives a message to the hospital that people of means and position in the community think this is important. And that changes attitudes and opinions as well. Those are some of our strategies.
So in the States, there's an organization called Gainey that surveys patients about their satisfaction of with care. I don't know if that's occurs in Canada also. But if your results as a healthcare institution, if you do poorly on a survey, that potentially impacts your reimbursement. So one strategy would be to approach organizations like Press Gainey to add or accentuate the the more humane aspects of medicine, and because then ultimately hospital leaders are concerned if it hits their bottom line, and so if they're getting negative reviews, I mean, you mentioned that UNH is the 7th best hospital in the world. I mean, I don't know how anyone figures any of this out, but it's probably a result to some extent of these kind of surveys. So if you could, professional societies would have potentially have an impact rather than doing it on a hospital basis, but try to do it on a systemic basis. If you hurt the bottom line, then they might wake up. I don't know if in Canada there's a bottom line that you have to worry about.
It does affect reputation.
Hi, thank you, Dr. Hertz and Dr. Gary Rodin for your talk today. I just want to bring up an issue that I've been seeing in my practice. I do clinical trials, and I used to work in transplant, and now I'm in anesthesia, and I do agree with you. Mental health in general is very underfunded based on my experience personally in the practice. And a lot of the funding is geared towards interventional studies, drug trials, and that's where the bulk of the money is towards. And I guess my biggest question is, how do you see, how can we bring more funding towards mental health research and building more workshops to really educate patients and also healthcare providers moving forward? I guess that's my biggest question.
I mean, one of the things we haven't talked about is about why things are organized the way they are, is that there are commercial drivers of this. So that drug trials are funded by pharmaceutical companies, and both in terms of money and resources and reputation, they get driven, whereas psychological studies don't generate revenue in that way. So I think one solution is, when we're talking about advocacy, there need to be advocacy at the level of research funding bodies to be funding psychological research in the broadest sense of that word. And I mean, I shouldn't even just say psychological, I mean quality of life, well-being, palliative, all these things need to be equally resourced. There's biases in each of these in the major, and it occurs, by the way, I'm a psychiatrist, it occurs even in psychiatry. I don't know if anybody has seen the book by Tom Insel. He was the head of the NIMH, I don't know, for 8 or 10 years, and he put it all into neurobiology. All of the funding in the NIMH went into neurobiology, the biological aspect of psychiatric illness. And at the end of it, he's now said it hasn't accomplished anything. He had a daughter who developed anorexia nervosa, and the only thing that helped her was, the only evidence-based was family-based therapy. But he didn't put a penny of that, of the money of the NIH into that kind of, and that's what happens in all of, so that's even in mental health, it's focused on the biology rather than on the human aspect. So there needs to be a shift in thinking, and it requires a concerted effort by leaders in the field. And that's what we're trying to do in this project on biomedicine, the soul of medicine. And the good news is that this psychological research, quality of life is way less expensive, so that it could be done on a fraction of the cost. So it's about, again, it's about bias. It's not really about resources, actually.
I feel that we are under a trend of so-called fragmented medicine. I think that's where the future of medicine is fragmented. There are many components that don't seem to connect with each other. And I think one of the kind of aspect that we highlight today is this physician, healthcare worker connecting with the patient. I think is much needed. And it seems that this is a much bigger systematic problem that had to be addressed at multiple levels. And even medical school, they should have some training about teaching doctors how to talk to a patient. I just talked to Gary before the meeting that I had a recent experience with a fellow, nephrology fellow, so pretty senior trainee, who called me in a panic to say that the family of a patient is very mad, and can I talk to the family? And I said, have you talked to the family? And he said, no, but I'm too distressed to deal with that. Can you do it? So it just illustrates, this would be something that I would expect any medical trainee to take it as an opportunity, because like if you're afraid of the patient and the family, how do you practice medicine? I mean, and if you cannot talk to the family, so I think it just illustrates kind of a deficiency of our system, and I think that so I'm not. I think the solution will be very complex. Like whether we can actually fix it or not is not clear. But this is the trend that we are heading, and I think that there are. I personally think that having more kind of discipline type of meeting like this kind of bring out the issue to the open. It's very helpful. Certainly today I learned a great deal, and I kind of think that this is something that I will try to remember next time when I see my patient, like that there's another aspect rather than telling them the diagnosis, and that there is something that we tend to forget. And I think that, like William Osler once said, always comfort, often relief, seldom cure, is still very much applicable to today's medicine. I think that we tend to forget that we can always comfort, and that is part of a therapeutic plan that we should try to implement. And So I don't know if you have any comments. If not, that we can close this session and then just have a coffee break. And then the next session will be on metabolic health, and then we will have two outstanding speakers talking to us about a very interesting aspect that